Good morning, everybody, and welcome to our Healthy Breakfast. I'm Helen Pickering, Head of Healthcare at Curry & Brown. So this Healthy Breakfast webinar is the latest in our social value series, and we'll be focusing on technology and the impact on social outcomes. We've got some great speakers today. We've got Martin Clark up first, who's the Head of Healthcare Advisory Services at Curry & Brown. He's going to set the scene on social value and technology. We've then got two speakers who we're currently working with. First up is Catherine Henderson from NHS Lanarkshire, and she'll be discussing the digital planning process for the new Monklands Hospital and how that is linked to social value. We then have Claire Orchard at Milton Keynes University Hospital NHS Foundation Trust, and she'll be sharing her experience of a digital twin pilot and the social value impacts. The presentation will last 30-35 minutes, following which we'll have a Q&A session. If you click on the Q&A button, you can submit questions on the right-hand side of your screen, so please do that, and then at the end I'll ask them as part of that Q&A. The webinar will finish by 9:30 and the slides and a recording will be made available to you all. So to kick us off, I'd like to hand over to Martin Clark.
Thanks, Helen. Good morning, everybody. So yes, I'm just going to provide a bit of context as to why we're looking at digital technology in the context of social value. So this is the second of our webinars looking at social value and benefits. Previously we talked about modern methods of construction. So I'm just going to start by a bit of recap what social value is, why it's important and relevant to what we all do. Then look at the place of technology in social value and why we need to consider the benefits of technology. So a number of different definitions of social value. Picked out a couple from Social Value UK and from some NHS economic appraisal guidance. I think the important point around those first two definitions is the emphasis on change, on the consequence of an intervention or an investment or a policy change. What that means for people broadly within society, how those changes impact on their lives, and the value they put on those changes. Social value has quantitative and qualitative aspects to it, and it's a sort of a comparative measure. And as the Green Book emphasises, it's an effect of value, a net value around costs and benefits, and how, as I said, any intervention, policy, investment affects broader welfare and well-being. Why are we looking at it? Well, it's become much more central in recent years, particularly to government's policy strategy spending. You can see a statement there from the recent Levelling Up white paper about social value being integral to government investment and expenditure. And then also a clear link between infrastructure and social outcomes and the benefits that infrastructure can have. So that's a bit of context around social value. It's as a concept, it's been around for some time. Social value out nearly 10 years old now. But as I said, it's really come to the fore in recent years in a whole wide range of policies and strategies, some sort of broader economic and construction related, some very specifically related to the NHS. I've highlighted their recent plan for digital health and social care because that really draws out benefits and social benefits of a whole range of digital policies and strategies within healthcare. And that leads us then into looking at the wide range of interventions. So you'll be familiar, really very significant breadth of initiatives, technologies available, policies and strategies. I've just highlighted some here. But looking then at, for those perhaps more prominent initiatives within digital and technology, what benefits they may be expected to deliver. And you can see we've got a number of different initiatives there relating to the use of data and the capture of data, to technology that enables us to monitor patients away from the hospital setting, to new initiatives such as virtual wards in terms of how we deliver care. And obviously we've had virtual appointments over the last few years, particularly through the pandemic. And then some infrastructure related technology around asset tracking, digital twins, which we'll come on to look at. But I think you look at these collectively, what you can see is a collective set of potential benefits that are relating both to the individual in how they access care, but also more broadly to society, and included in that the sustainability agenda and how digital might impact on net zero carbon. So you can see that technology is fundamental to benefits that will deliver social value in the future. So then looking at the question of why would we want to consider and assess and appraise social value benefits, I think this really comes down to the fact that we know that care is going to be more digitally enabled. That will require more investment. Obviously investment has been increasing, but it will need to increase further in technology. Which is exactly as things should be, but if we're in the context of constrained capital envelope, which inevitably we are and are likely to be, then if we spend more on technology, that means we're spending less on something else. So there's an opportunity cost associated with investment in technology, and I think that means that we need to be really clear around the benefits that investment in technology will deliver, so that we're not doing digital just because we can. We're doing digital, we're using technology because of the benefits it will deliver at organisational level, but wider societal level. So that's just really provide a bit of context on social value, technology, how they come together, and we're now going to look at some specific examples of that, of use of technology and of assessing benefits of technology. So now I'm going to hand over to Catherine to talk about some experience in NHS Lanarkshire.
Morning everyone. Today I'm going to be talking about the Monklands replacement project. It's a major healthcare infrastructure project here in Scotland, and I'm going to aim to give you an insight into our person-centred approach to digital design, whilst also demonstrating how that approach is linking in with the principles of social values. Before I get into that, I just want to set the context by giving you a brief outline of the project itself. So the Monklands replacement project will be a considerable investment in NHS Lanarkshire's hospital estate by replacing one of our existing acute hospitals, University Hospital Monklands, with a new state-of-the-art facility. This new facility, we're designing it to deliver a new model of care that's going to shift the focus of care away from the traditions of long inpatient stays to one that's more focused on day case, day treatment, outpatient and community-based services. In terms of status, the project's nearing completion of the stage 2 design, and we're preparing for submission of our outline business case to Scottish Government towards the end of this calendar year. So we're very much working within that conceptual design phase, and I'm sure you're going to get a sense of that as I talk you through our show. One of the big ambitions of this new hospital is for it to be digitally advanced, using modern systems, technology and data to support people and processes. So the start of our digital journey was to set out some of the overarching digital aspirations for the new hospital that could start to underpin our digital thinking and make clear that emphasis on people being at the centre. And you can see that beginning to emerge in our desire to use digital to support safety and efficiency, reduce inequalities, to continue to work in collaboration, and also to build a culture that encourages digital confidence and promotes well-being and sustainable clinical outcomes. We also thought broadly about big digital opportunities that building a new hospital presents to start raising the profile of digital. So in essence, we aim to create that sense of excitement and urgency that would ensure that digital was a design priority from the outset. And some examples of our thinking around that time included developing an integrated electronic patient record, which seems critical to delivering a digitally advanced hospital. And our thoughts also turned to how linking with the Healthcare Information Management Systems Society accreditation, or HIMSS, as I'm sure many of you are familiar, linking with that process could support that route map to EPR excellence. We explored the potential to develop a command control and we linked in with command centres across the UK and North America to learn lessons and valuable insights into that cutting-edge implementation that we could use for our own hospital and our wider organisation going forward. And we've also explored where robotics could add value, thinking about lab assist and how that could help to automate repetitive laboratory processes, buddy robots to reduce the impacts of isolation and loneliness, surgical robots creating efficiency in operational procedures, pharmacy dispensing arms for efficiencies in pharmacy, and automated guided vehicles supporting facilities management to automate routine tasks and reduce the impacts of labour-intensive moving and handling activities on our workforce. And we've even considered the potential to create that full digital twin, the digital representation of our physical hospital, and what the benefits might be to our clinical, operational and building management services. Again, they're just examples that I'm beginning to share to show you how that early approach to design was to broaden our thinking around digital in a way that was different to everything that we had done before. So we then set down some basic rules, for want of better words, to continue that journey of bringing everyone together in our approach. They were purposely simple and almost cliched, but they have helped to move things forward and they have encouraged us to challenge our digital thinking. So we endeavoured to work with stakeholders from the start, to start with the end in mind, to not make assumptions about what we thought we knew, to make sure that the focus is on need and not want, and not to implement digital for the sake of it, but to make sure it always added value. So we did work with stakeholders from the start, and led by our healthcare planner, we developed clinical and non-clinical output specifications that made clear the current as-is service delivery models and the future to-be delivery models. That allowed us to start developing transition plans, looking at short, medium and longer term changes that were required to realise these new models. And that set down a foundation upon which we could actually start to consider where digital opportunities might arise to help support the services. It was very important to us to understand how stakeholders wanted to deliver their service in the future first, before adding in the digital layer, so that people and processes came first and digital remained the enabler of change and not the driver of change. Our next step in bringing everyone together was to develop a shared vision, so linking our aspirations and key opportunities with an understanding of what the digital hospital needed to be. And we did that through the identification of core characteristics and key principles that could support digital decision making and prioritisation going forwards. So just to explain that a little bit further, as we start to identify potential digital opportunities, we can test that opportunity firstly against the characteristic wheel. So if, for example, we were thinking about implementing a new system, we could ask, does the system improve accessibility to healthcare or real-time data? Does that system create efficiency through automation, or would that solution help to connect people, process and place, and so on around the wheel? The strength of value is therefore in the number of yeses around the wheel. So 1 yes would be a weak indicator of value, and 6 yeses would be a stronger indicator of value. We can then further test that potential for value added by moving up a layer to test a solution against our 7 principles. So in essence, we've developed more than just a vision. It's a tool that's helping to guide our digital thinking and prioritisation. In parallel to building that vision, we've also taken a lot of time to understand the existing barriers to digital transformation perceived by our staff, patients and visitors. It's really important to us to break the status quo and make sure that we don't keep repeating the same cycles of multiple silo systems, access challenges, with multiple logins and timeouts, continuous access problems and poor interoperability. We've also learned that this is another good test against digital opportunities to make sure that digital implementation does make things better. We also learned quickly that the concept of a digitally advanced hospital, or digital hospital as it's often referred, in its entirety is quite an overwhelming prospect. So we broke it down into themes that could help us connect with different groups of people and make the idea of a digital hospital much more meaningful and less daunting. This breakdown into themes then helped us take the conversation to a wider stakeholder audience, and we started to build up user stories that would again ensure that we as a project weren't making assumptions about what people needed. So I've got an example of a generic patient, and this same approach can be applied to all stakeholders. And it just starts to set out that as a patient, I don't want to do this, and as a patient, I do want to be able to do this. And we start to see how digital might be able to support some of that by developing those thoughts into ideas. And when we start to turn these user stories into ideas, we can see that the patient who may want to navigate the hospital easily may want to use an application to do that, QR codes, digital signage and so on. We can see that the patient who may want to self-manage appointments, we may be able to support that through access to self-scheduler. A patient who may wish to access their own records, we could introduce patient portal and so on. So very much taking the user stories and turning those into ideas. And then we take those same ideas and we try to create a more visual concept, turning them into images that start to give us the look and feel of how those ideas might be in our new digital hospital. So that's a quick tour of our concept approach to digital design and our journey so far at outline business case stage. And you'll appreciate that much of what I have shared is therefore relatively high level, and the detail will start to be developed more into our full business case stage and stage 3 in design. That said, I believe that taking the time to get the approach right has been invaluable, and it has set down a solid base upon which we can continue to build and refine our requirements. And if I take a moment just to take us back to what I said at the start about linking our approach to the principles of social values, and we can start to look at the 7 principles that you see on the screen there, and we start to see that the approach already ties in by involving stakeholders from the start and at every step since, which has also created transparency across the system, taking account of what needs to change by starting with the end in mind. We've developed a framework vision that tests our thinking and helps us to prioritise the things that matter and add value, and also understanding the change. I expect that there has been a lot of familiarity to some of the things that I've shared today from your own experiences and processes, but I do think it's really good to keep sharing these approaches and ideas, because even one small change in how we're approaching something can make a big difference to outcomes. So on that, I thank you all for your attention, and I will hand over to Claire.
Thank you. So hi everyone. I'm just going to talk you through Milton Keynes University Hospital's pilot that we're doing here around digital twins, and how digital twins can essentially capture social value. So a little bit about Milton Keynes and digital. We are very proud to be a HIMSS 5 site, and we have a roadmap to get to 6 and 7. We are accredited digital leaders through the Global Digital Exemplar Programme. We're also cohort 4 of the new hospital programme, and combining this all together, we have a great ambitious digital strategy that's just been developed to lead us through to 2026. So how can digital twins capture social value? First, we need to think about the environment that the value is being generated within. As humans, we're really good at reading our environment in order to gauge what's going on. And to do that, we use our senses to get a real-time view, and also our lived experience to judge how best to make a decision on what to do next. In the built environment, a digital twin needs to do just that. It needs to know where things are, understand what things are doing, and then apply logic to make a decision around that social context. So when humans interact with things and people in their environment, we call this socializing. And there are benefits to socializing, and one of those main benefits is well-being. Unless you're a huge introvert, you don't like socializing. So a digital twin can support the very human aspect of our jobs, first of all, in helping us to communicate and collaborate better. And if we want to automate decision making through digital twins, we need to get a really good feel for the social context in which things are happening before we can do that safely. So I put some statements down there on the right hand side. around what positioning, perceiving and questioning is. I'm sure it's all very obvious because we're humans and we know. And the social value statement there that was also in Martin's slide. So that is the quantification of the relative importance that people place on the changes that they experience in their life. If socializing is a good thing and it's giving you a benefit, then you're going to value that as higher. If it doesn't, you're not going to value that as much. So some examples then. The first one is an air handling unit. This is quite a simple one. The position is that it's in theatre 3. It has a servicing alert coming up on that air handling unit. So that's the perceiving. The digital twin would perceive that. And it could also perceive that the air handling unit is in use. The questioning then, the logic around what to do next would be, you know, is a question, is the alert coming from a scheduled maintenance alert, or is it actually a fault? And based on those two kind of questions, you can automate the next step, which could be to schedule a scheduled maintenance session, or to send a message straight through to a person to say something really urgent needs to be done right now because this is in use and there's an issue with the piece of equipment. Another example could be a patient monitor. So that could be in room 5 as an example. The monitor is alarming because a patient's heart rhythm has changed. And the questioning around that could be, well, who's looking after the patient? Who needs to know this right now in order to help? So that could be an automated message to the nurse supporting the patient. Another example could be a patient monitor on the patient itself, understanding where they are. And they could be moving towards an exit. So that would be the digital twin perceiving the patient moving towards an exit. And the questioning could be, well, is it safe for that patient to move to the ward's doors or not? Is there a safeguarding concern? Is this a paediatric patient, a patient with dementia? And that could be an automated message to alert someone to the movement of that person and their whereabouts to keep them safe. So some benefits of social value. Social Value UK make these 5 statements here. They maximise the value that you can create. If you know where that value is, then obviously you can home in on that and maximise it. They allow you to involve the people that matter the most. So digital twins, you know, again, getting back to the value you put on, or the measurement you put on the interaction you're having, you can kind of then gauge who you actually need to interact with to get the best value. They allow you to give a competitive advantage. In healthcare, that advantage would be improving the outcome of patients. And also they enhance communication internally and externally, and ultimately allow you to gain funding and contracts as well. So our digital twin at Milton Keynes University Hospital, when we were first thinking about what it could do for us, we strategized around these 5 things here, and this is what we wanted to look at first of all. First, we wanted the digital twin to support our workforce and clinical strategies, which are going to be changing in the future because of our new hospital programme that will be coming to Milton Keynes very soon. And we particularly wanted to concentrate on the single occupancy room theme that is coming through the National New Hospital Programme as a standardised feature, and how that might impact our workforce and clinical strategies. We also wanted to investigate patient experience and safety, better utilisation of space within the environment that we're operating in, and then putting the right people together at the right time. And importantly, we wanted to test the opportunities through IoT technology. There's been a lot of hype about IoT technology over the last few years, and we're now kind of going over that hype arc in the development cycle and kind of heading down towards the, well, actually, what do these benefits actually look like? Can the hype actually fulfill some of the things that we thought it could do through benefits? So to create our digital twin, we worked with a company called Halcyon, who offer quite a few smart building solutions within their organisation. We are using ThingSee, occupancy sensors, and also a Cooper positioning system. And both of these systems are integrated into the empathic building solution that Halcyon offer. So essentially, it's integrating all that data from those sensors into their platform and displays it on a really fun an intuitive app. What you can see there is a picture of our cancer centre ward and what the digital twin looks like. We're very proud to be one of the first NHS trusts in the country to trial this technology. I'm sure we won't be the last, but with that comes a lot of time and effort looking into actually what those benefits look like and testing that with our organisation to make sure those benefits really are driving a positive change. So why did we choose the Cancer Centre for this pilot? That's very important to mention. The Cancer Centre at our hospital is quite a new building. It was commissioned in 2018. And with that building came a modern ward design compared to our other wards on site. We have single occupancy rooms within that ward. And we also have some very up-to-date building plans and maps. So it was much easier for us to build our digital twin. What you can see on the right-hand side there, hopefully the video will play in just a moment. We have the map of the ward, so you can see kind of a bird's eye view of what it looks like. You can see the single rooms there, and you can see different colours. Red is showing where a room is occupied, and blue is showing that it's unoccupied, or at least there isn't any movement sensed in that room. You can also see sensors that are picking up on the counting of people into bathrooms and the percentage of paper left in paper handheld dispensers. And we also have a lot of assets being tracked in the building, Welsh Allens, wows, defibrillators, scales, hoists, lots of different things. People are starting to be tracked around the building too on a voluntary basis. And we also have desks. You can see just there highlighted red, amber and blue desks show if someone's sat there or has just sat there. We can also use the platform to look at heat maps. So this has been really interesting for us to test the model of care within the ward and through occupancy. So which rooms get used the most, where are they, and then go with this map and this data to kind of have those discussions with teams around how they're working. Is it helpful that a sluice is actually at the other end of the building when you've got your high acuity patients at the complete opposite end because it's closer to a nursing station, as an example. So hopefully that gives you an idea of what the digital twin looks like and how we're using it. So the data we're capturing to capture that social context is spatial data, assets and people. So just to kind of briefly outline what those are, we're measuring desk activity and room activity. We're also counting those visits to bathrooms and the levels of consumables through those bathrooms. The assets we're capturing do tend to be medical equipment at the moment, but we're looking at extending that out to domestic teams, so cleaning trolleys and bits and pieces there. And people, like I said, we've started offering people the opportunity to wear location tags that can pick up on where they are. We've had some really positive noise back from the staff in the ward who tell us that they are actually now able to find each other much quicker, find their equipment much quicker, which all helps when you're working in a ward that does have a lot of single rooms. So the outcomes of this pilot so far, we've been able to test and verify that we can monitor real-time and historic data to visualise those clinical and workforce models that currently exist and then look to potentially build on those. We're now really easily able to engage with the staff on the ward to test future models of care. We are proving through the staff on the ward that they're able to reduce the time spent searching for assets and people. There is the very early signs of cost saving through the reducing of the need to buy surplus equipment. So if you know exactly when those paper handheld dispensers are running low, you can change them at that point in time rather than, it looks like it's going to run out within the next couple of hours and I'm not going to come back to clean for a while, so I'll just change it anyway. So it's reducing waste as well. It's hopefully this is starting to emerge, but we're investigating how we can integrate other systems into this platform, such as nurse call, to increase patient safety within those single rooms. So it could be that the sensors and the nurse call equipment both integrate together to give us a really good idea of what's happening in the room and alert us if something changes that we're not happy with. And ultimately, all this combined increases our opportunity to automate processes and things into the future. Because if you could imagine if even one of these social contexts was missing, we make some huge assumptions around those automation processes, which is a risk in itself. So this has been a great opportunity for us to test what we can safely automate. And we're really excited to go forward and start testing a little bit more of that in the next few months as our new hospital programme develops.
To me. So thank you to all of our speakers. That's some really informative presentations with some great content, both from the kind of perspective of setting your digital priorities through to actually seeing some in action and the real benefits being achieved. So yeah, thank you very much. I'll move on to questions, and I'll encourage people to submit. We've got a couple here. So firstly, probably best for Catherine. How are you factoring in the costs, both kind of the upfront capital costs and the ongoing costs in terms of prioritising your digital plans?
It's a good question, because obviously everything's quite conceptual at this stage for OBC. So the building network and digital infrastructure costs are very much based on outline digital requirements. So our IT points, wireless access points, node rooms and cabinets and so on. And that's allowing us to kind of set a cost around the infrastructure side of things. In terms of the equipping solutions, a lot of that at OBC stage is done by benchmarking against other similar scaled projects, so that we can start to benchmark, but bearing in mind that we may be 6 years further on before we actually implement some of that, there's also a level of contingency built in around that. In terms of the ongoing running costs, we're probably a bit further ahead than many in terms of looking at our revenue costs in more detail than you might normally do for OBC stage, and there's two reasons for that. One is there is quite a significant shift in workforce requirements, so there's some hugely detailed work that's been underway to try and understand, I guess, what you might consider a worst case scenario as we start to bring in digital solutions and so on that will help to support that future workforce and create some of those efficiencies, and also around our energy costs. So you may have noted in one of my early slides, we are a Pathfinder project for net zero, and our current strategy is all electric. So you might imagine that that has increased some of our energy costs at this current moment in the current climate. So there's a lot of detailed work ongoing around that to give us a reasonable figure, which we hope will be worst case scenario and ties in with the current situation around us.
Thank you. So I'll just move on to another question. Probably Martin, if you kick off on this one. So you talked about a number of digital technologies. Do we have a sense of ones that are likely to deliver the greatest social value?
Yeah, so I think where the value is going to come is around the shift of care, and what's often referred to as that left shift around the technology that enables things like monitoring of patients with chronic diseases to happen remotely, the technology that reduces the need for people to come to hospital, to whether it's for outpatients or for testing, or for just going to ED and those sorts of things. I think that's where over time we can see that greater social impact. But I think the point with this is that we're from projects we're involved in and from conversations we have with various NHS organisations, including E&I, is that we're at early stages of really having that quantification of benefits from digital technology. A lot of focus is on what we think the technology can achieve, but there needs to be more embedding in that. And obviously, I think a lot of attention through the pandemic on the benefit for people of virtual appointments. But then there were a lot of counter arguments, but what we haven't got is that body of evidence to really quantify that. But I think, as I say, where we'll see the greater social value over time will be how digital can change the way we access care and make it easier for us all. I suspect that's where, as individuals, we're going to attach the value.
Great, thank you. Thanks, Martin. So on to the next question. One for Claire here. Claire, are there any disbenefits you've experienced in relation to the staff and patient privacy, and how have you managed those?
So I think the disbenefits are that there's always disbenefits in every project. When we first talked to staff about the idea of tracking them, and maybe in the future looking at tracking patients, obviously there's a lot of GDPR laws out there that we need to abide by, absolutely. But when you look into this, it's all around you know, people volunteering. It's the choice. If they would like to be tracked, they can be, and they need to acknowledge that properly. And if they don't, absolutely, they shouldn't be asked to or made to. We absolutely can't do that. But with those laws and with the idea of being tracked around the building being discussed, it makes people anxious. So when we first went into this project, the disbenefits we felt would be the not being able to capture the social context properly if we've got that missing. And what we've found as a benefit actually is when you introduce this technology and it shows straight away so quickly how beneficial this technology can be in helping people find each other and things, those benefits outweigh the disbenefits. We use this sort of technology in all of our lives. We're constantly being tracked around the place, and you know, that's fine if we're getting something from it, but if we don't, then that isn't fine. So a huge benefit that this technology is so easy to implement, so quick to implement and start showing people the usefulness of it, so that we can kind of build on that to hopefully negate any disbenefits around people tracking and anxieties around that as well.
Thank you. One for Catherine, kind of looking at the system-wide kind of an interconnectivity, and how have you managed that in terms of digital prioritisation, linking in with your kind of wider organisation and partners?
Yeah, so that really talks to that working in collaboration. So it's quite difficult as a project, as you may imagine, to implement independently of the wider organisation. So even in terms of us moving forward with tests of change for some of these digital aspirations, we rely and will rely heavily on our IT colleagues, our facilities management colleagues, our clinical colleagues. So we have a digital group essentially that comprises all of those representations, and we're taking things forward jointly. So we are developing a joint delivery plan that will set out the project's aspirations along with the organisational aspirations, because there's very little that we will do for the Monklands Hospital that we wouldn't seek to scale out to our other acute hospitals where that's possible. Of course, there might be some limitations around existing infrastructure, etc., of the buildings themselves. We've got this unique opportunity with the Monklands project to design in digital from the outset. So there may be one or two things that we can't aspire to do on the other sites, but everything's been done with the organisation in mind, and we're working extremely closely to develop those joint plans.
Great, that's really helpful. Thank you. There's just one more. So Claire, this is kind of more of a practical point about how it's monitored and how the alerts work, and how would you know that someone's in the wrong place, or so how does it, what kind of effort, I guess, is needed? Is there someone sat there monitoring it, or is that all automated?
So automation, I think, is something that's going to come much later in this project. Right now it's about capturing the data and then starting to apply logic to that so that we can automate it safely. At the moment, we have a screen that's at the nurses' station in the ward, which tends to be, because we can see the data now from collecting information around where assets and people are, that tends to be where people, staff collaborate the most and gather the most. So we've put the screen there that allows them to see what's being monitored. We want to extend that out to digital devices so that rather than have to go back up to the nursing station to see this screen and to see the map, they can look at that on the go. The reason we've done it in that order is because we want to actually start looking at this data and testing the change as we kind of move into that more agile working and starting to put all of that data into the hands of staff. And once we've done that, we can then start thinking about integrating with other systems. So with the EPR to give a patient context, with the nurse call to give that kind of understanding of what's happening in the room as well. And it's quite likely that we'll use alerting through not just this digital twin, but through those other systems as well. So it could be a nurse call alert that's taking extra information from the sensors and making that automation process safer. It could be an alert through the EPR again that takes information from sensors and from nurse call and passes that back to EPR. So very early stages at the moment, but that is kind of how we hope to move it forward.
Thank you. I'm trying to spread the questions around. So Catherine, another one for you. So you've talked a lot about how you're prioritising the digital in relation to clinical. How are you prioritising for non-clinical digital solutions, so things like AGVs?
Yeah, so essentially it's the same approach that we're using, and that's why we spent quite a lot of time developing that approach so that it could apply to all areas, both clinical and non-clinical. So we are similarly running user stories for our various job families across our facilities management and within our IT department also, since it's a digital hospital, there'll be an increase in digital input into that as well. And we're also turning those into ideas and then helping to visualize those. And actually a lot of what we're doing as well is visiting at the moment. It's a big discovery phase for us through OBC to actually understand the art of the possible. So there's a lot of site visits to other organisations, not always healthcare. Quite a lot of our visits are to universities, to some of the innovation centres, because we are some way off. So almost our decision making has to align with that horizon scan and when is the right time to make the decision about what digital solutions we'll bring in. So to answer the question, it's very much the same approach, and it seems to be working very well in terms of how those non-clinical services will deliver their service, and then layering digital over the top and having those ongoing conversations about what we think the opportunities might be to support that through digital solution.
Thank you. That's really helpful. So the next one is a bit of a general one, really. So maybe Martin, you might want to kick off and hand to others. And it's sort of in a world where we've got increasing digitalisation. What are the biggest challenges do you think that we face?
Yeah, so I think that there's a couple of aspects to this from what we're experiencing. Obviously, it'd be interesting to get Claire and Catherine's take as well. But I think, you know, one of the things that probably comes across from what we've all been talking about, but what people are experiencing, is that the scale of different digital technologies and possibilities and options means it can be quite hard to move from, you know, what is the art of the possible to what do we really want to use to deliver the most value or to solve problems, or where we're going to get the greatest gain. And potentially linked to that, I think, you know, some people are taught to sort of relay the fact that there's a lot of extremely you know, able and clever people involved in all the digital, but it can sometimes sit a little bit outside more strategic planning, estate planning, infrastructure planning, general. And we know that the move towards looking at infrastructure strategies across systems is going to force that need for digital, for building planning, for sustainability to come together more. And I think that's where both Catherine and Claire's presentations are interesting, because they show how digital is being considered at a very early stage in planning processes. I think that's where a lot of the challenge is how we bring all of this art of the possible through technology in right at the beginning, when we're looking at clinical strategies, when we're looking at state strategies, and when we're looking at developing, you know, plans, designs, and so so that we're not trying to piece together things that are being developed in isolation. Certainly those are sorts of challenges that we're encountering in the work we do in this space.
Thanks, Martin. Claire or Catherine, did you want to come in, or?
I don't mind coming in. So yeah, I think one of the biggest challenges is working out the difference between digital development and digital transformation. So we always say the NHS is really behind when it comes to technology, but actually we're not. We're quite advanced already. We are quite digital. And a lot of the projects we run aim to be transformation programs, but what they are is actually development on top of what we've already got. So the sort of technology we're looking at when we're thinking about digital twins as an example is true transformation. How can we completely use technology to completely change the processes and the way of our working for the better? And when you start thinking about how you engage with the market to bring that technology in through to the NHS, a lot of the technology you're talking about hasn't been tested yet. So you kind of get into the realms of, you know, the hype cycle. At the moment, this is really being talked about as the next best thing. It's going to be amazing. But you do have that downward trend sometimes for a while where you think, well, actually, it wasn't this magic pill that we thought, excuse the pun being healthcare, but, you know, magic pill that we thought was going to help us solve all our problems. So I think where the NHS has a great benefit is that it's dominating the UK healthcare market. There is very low barriers to someone else coming in and taking that away, which is brilliant. We love our NHS, but we've got a real chance to kind of define what this market and the new technology looks like through healthcare after that hype kind of comes and goes. So hopefully we're sort of dealing with that very, very well at MKUH with our pilots and testing all that technology into the future.
Thank you.
Back over to Catherine.
Thanks, Claire. Thank you, Claire. So there are no more questions in the chat, so unless anyone wants to submit a last minute one, I will thank our speakers. I thought it was really, really interesting, obviously a very topical subject. A lot of NHS colleagues are kind of considering right now in terms of prioritisation and also looking at the value of different technologies. So really informative. Thank you very much. The slides and the recording will be made available to all attendees, and thanks everybody for joining.